Welcome to Patients at Risk, a discussion of the dangers that patients face when physicians are replaced with non-physician practitioners. I'm your host, the co-author of the book Patients at Risk and the author of the follow-up book Imposter Doctors, Rebecca Bernard. Today we're going to continue to listen in on testimony from the Texas State Legislature's interim hearing on scope of practice. You've already heard some of my testimony, as well as some from a nurse practitioner, and today we're going to listen to testimony from the Texas Medical Association president, Dr. Ray Callas. And we're also going to hear the line of questioning from legislators and some of Dr. Callas's answers to those questions. And I think it's really important to hear those questions because it helps us to understand the perspective and the thought process of our legislators to be better prepared to respond to them. So let's jump in to listen to Dr. Ray Callas.
My name is Ray Callas. I'm a board-certified anesthesiologist practicing in rural Beaumont, Texas. I am the president of the Texas Medical Association, representing over 58,000 men and women, physicians, medical students, and retired physicians. In short, the existing legal framework for addressing health care in Texas protects the health and lives of Texas patients and to ensure Texas receive care by licensed physicians who are trained to lead the healthcare team. This framework definitely works. When addressing access to care, the last thing we want to do is lower the standard of care to this well-constructed framework to jeopardize patient care. Simply put, there are right ways and wrong ways to address the issue of the shortfalls we have in Texas. The wrong way is to put Texas patients at risk for their health and lives by allowing those who have not completed the necessary training in the medical school and residencies to unsupervised care of the lives of the Texans that we serve. Texans we want to ensure 5 things. 1, that patient safety is always going to be utilized with proper diagnosis. 2, ensure life-saving measures are properly and quickly acted when a patient is most vulnerable to a medical risk. 3, ensure quick access to medically competent care without delays. 4, healthcare dollars are not wasted unnecessarily on tests, prescriptions, or other type of procedures. And then finally, ensure profit is not supplanting the do no harm oath that us as physicians in caring of Texas patients and their families, we take very strong and consistent. Current Texas law, authored by and sponsored by Chairwoman Colcourse, is working and allows nurse practitioners and other providers to work in medical teams on patient care under direct and or regular supervision oversight with a licensed Texas physician. There are no distance limits on these delegation agreements, and to be clear, nurses can practice in rural areas if they want to with the oversight of a physician. However, repeated studies reflect that nurse practitioners seek to provide care in urban and suburban areas. Physicians have unmatched education and training, making them uniquely equipped to lead healthcare for the Texans that we all serve. Physicians have 4 years of medical school. We have 3 to 7 years of medical training and residency, about a total of 12 to 16,000 hours. In comparison, nurse practitioners generally complete a master's degree in 2 to 3 years, have only 500 to 720 hours of training, and have no residency requirement at all. In other words, physicians have approximately 20 times more clinical training compared to nurse practitioners. By analogy, would you let a pilot who only has 5% of flying capabilities fly a plane with you and your family? No, you wouldn't. So why would you jeopardize your Texans with that? Since the passage of the Affordable Care Act, there has been a dramatic increase in nurse practitioner programs from 382 in 2005 to 978 in 2018. Most of these programs are mostly and completely online, and many accepting 100% of applications. There are also direct entry nurse practitioner programs open to students and masters in nursing before they even have a nursing bachelor's degree. Furthermore, recent studies on allowing nurse practitioners to practice independently have documented the dangerous and negative effects on the quality of patient care associated with increased health care costs. The Hattiesburg study that I looked at and I presented at the American Medical Association was in Hattiesburg, Mississippi, and what it did after allowing nurse practitioners and PAs to function independently in primary care, Hattiesburg Clinic in Mississippi performed a 2-year study that compared physician versus non-physician oversight with quality outcomes. Their results found that non-physicians performed worse in 9 out of 10 patient care quality measures. They also found that patients who had non-physicians as their primary care cost an average of $43 per member per month. And also, if there was a cost adjusted for patient complexity, it was up to $119 per member extra per visit. Non-physicians had higher rates of referrals to specialists, which cost taxpayers dollars, and it also burdens the financial burdens on the state. Patients also of non-physicians were more likely to visit the emergency rooms, even though these patients were younger and healthier, according to demographic data and risk scores. After assessing outcomes, guess what Hattiesburg did? They went to a physician-led healthcare team model after they did the study. So they're now back to where a physician leads a healthcare team. A VA study, which I'm very proud. I'm a former Gulf War vet, served during that time, and I'm really proud to serve this country. The VA did it likewise. A recent 3-year study evaluating the independent nurse practice in the U.S. Department of Veteran Affairs. Emergency departments found nurse practitioners practicing independently had 20% higher rate of preventable hospitalizations, increased overall length of patient stays by 11%, and raised the cost of care in emergency department by 7%. The reality is that special interest groups whose agenda is now putting patients' lives at risk by replacing physicians with non-physicians, the goal of private equity group entities is to increase their profits on the backs of patient safety. Clearly, this is definitely the wrong way to improve access to care. Expanding non-physician scope of practice is simplistic, dangerous, and short-sighted approach and puts Texans and their families at risk.
So Dr. Callas has laid out the facts around education and some of the concerns. And in this next section, I was really impressed with the way he focused on what the Texas legislature has done proactively to encourage and grow physician-led care. I thought that this was really compelling, and I like the way that he presented it. So take a listen.
The alternative, the Texas legislator has acted responsibly in meeting this challenge with responsible policies. And I thank you all from around, all you senators that has helped with this. You have done an amazing job in helping grow our physician workforce. I just want to give you some totals of what y'all have done so far. One, in the past 2 years, we have licensed more physicians than we've ever done before. We licensed 7,700 physicians new this year. Additionally, our rural ratio of family practice physicians to patients is better than the urban ratio right now. Last session, the legislators found funding for physician workforce at record levels. 100% in rural resident training programs, thank you. 17% in increased GME funding, thank you. 74% in family medicine residency training programs, thank you very much. And then 21% joint admission Medicare program at economically disadvantaged students. And finally, 21% increase in physician education loan repayment program. You have laid the groundwork for the physician's workforce to grow in Texas, and for that, I applaud each and every one of you. Increased access to care in underserved areas is challenging, but it can be achieved without compromising quality care or patient safety. Texas has already made significant progress in reducing the number of health professional shortage areas. In 8 years, Texas has reduced that number by almost 30%. Going forward, adding 80 primary care physicians to the workforce in the right places could remove all health professional shortage areas. And finally, in closing, when patients have medical needs, they do not and should not be forced to accept a lower standard of care. This can cause patients to suffer from improper care, increase patients' insurance costs, and waste taxpayer dollars, and delay the care of patients. So I applaud you for what you've done for us to allow us to take care of our patients. And I also applaud allowing us and our nurse practitioners and PAs working together to take care of one thing, and that's to take care of our patients. So thank you very much.
That concludes Dr. Callas's remarks, and now we're going to get into some of the questioning from the legislators.
Thank you, Dr. Callas. And so I'm going to start with Senator Blanco because he carried the bill last session and was very patient with me and our conversations, and always appreciate your insights, Senator Blanco.
Thank you, Chair. Appreciate your leadership and look forward to a great conversation. Dr. Callas, thank you so much for coming. I do have several questions for you, and appreciate your service. I too am a Gulf War vet, so thank you so much. Appreciate it. The sections of the occupation code and the administrative code that govern the delegative responsibilities of a physician require adequate supervision. Adequate supervision of the APRNs. However, there's no explicit definition of what that means in those sections of the statute. Is that correct?
That is correct. Yes, sir.
Okay. having said that, so there's no consistent supervision standard. Is that accurate? And the level of supervision is primarily at the discretion of the delegating physician based on their judgment of the APRN's ability to provide the services outlined in that delegatory agreement. Is that accurate?
No, sir, Senator. I will tell you, I started on this delegation order many years ago when Senator Nelson was there for Senate Bill 406. I will tell you, I came to the table, and that was when I was a younger physician leading legislation and trying to partner and have a collaboration with the APRNs to take care of Texans. Since that time, we also loosened the oversight because we had collaboration again where the nurse practitioner said, hey, why can't we decide what fits best between the physician and the nurse practitioner? So the reason why it's so loose right now for oversight, we can make it tighter, but that was not our intelligence. It was us collaborating with the nurse practitioners. What we're trying to do is to maintain oversight because of our education, our expertise, but under no circumstance do we want to put patient safety. But I'm not saying you're wrong. I'm just saying that it was not us saying we don't want to oversee. It was us collaborating with both sides, making sure that we take care of patients.
So this was really interesting to me because what Dr. Callas is explaining is that earlier in the legislature, physicians were asked to make it easier for nurse practitioners to practice. It was sort of a compromise because nurse practitioners have been asking for independent practice over and over again. And so I think the legislators were getting pretty tired of hearing about it. They're tired of hearing that NPs are saying they're having trouble finding a supervising physician. It's too cumbersome. It's too much burden. They can't get to the rural areas. So the legislators asked physicians, can you please come to the table and work something out? We're tired of hearing about this. So as Dr. Callas has expressed, that's exactly what they did. Texas came to the table. They said, okay, well, if we'll negotiate, we'll give you a little of this, we'll loosen this up, we'll try to make it a little easier. They did that because they were told that that's what they needed to do. And now what you see is that that's actually backfiring. Because we have allowed some loosening of supervision, it's being used against us to say, well, you're not even really supervising, so why do we even have this? So it was a lesson for me because a lot of times I know I've been told when I've been working in advocacy, well, you need to negotiate, you need to come to the table, give a little. And I think what I've learned is that if you compromise on your integrity and what you think is right, what ends up happening is a very slippery slope. And it ends up actually being used against you. So I think the lesson for states that are still holding firm or states that are considering making some changes, we really need to make sure that proper supervision is happening, that it's not just in name only, because if so, that's going to be used against us in order to justify independent nurse or PA practice.
Okay, so from your perspective, what does supervision and that maintains quality of care and safety entail?
I'm glad you asked me that. I oversee CRNAs, which are Certified Registered Nurse Anesthetists. I supervise them 1 in 4 model. I don't even go to 1 in 7. And the way I do that is I have to hit 7 criteria. 1 is making sure I do a history and physical and evaluate that patient on my own. 2, make sure I'm there for the intubation part and make sure we come up with a plan. 3, make sure I'm readily available within that facility that I can go into the operating room right now and see them. 4, I got to be there for extubation. 5, I have to make sure that I'm there for post-recovery. And 6, I discharge them out. And then the 7th is make sure that we collaborate together. So my definition of oversight is the same thing you would agree from a military standpoint, that I knew I was enlisted and I knew I had officers that would oversee me. That's the way I medically supervise and direct. I will tell you I'm not a primary care physician, but I will tell you that I would prefer that we have more oversight than less oversight. And the other thing I would highly recommend we do.
So let's go back to the current statutory requirements. Can you expand on what that what the requirements are for supervising and delegating physicians are.
Yes, what that means is that a physician can oversee and supervise and delegate over 7 APRNs. They also can make a decision on how they want to visit. They can either do it via telemedicine, they can do it by a phone call, they can do it by depending on both sides, meaning that the physician with a nurse practitioner, they can decide what they feel is very clinically relevant to maintain oversight. I'm not in that practice to dictate and delegate what I think is appropriate care. I think that if you have a nurse practitioner or physician that both agree, sometimes if they're well experienced on both sides, they don't need that much physician oversight and delegation. But with that being said, I know that the orders is that it's a collaboration between the physician and the nurse practitioner.
You said 7. A physician can have up to 7.
Yes.
So you had mentioned SB 406 earlier, established that a facility-based hospital practice that serve in medically underserved regions, there's no limitation.
Correct.
Okay. So given that 70%, roughly about 177 counties in the state of Texas, are designated medically underserved, is it accurate to affirm that physicians can delegate medical acts to unlimited number of APRNs in the majority of our state?
I haven't seen that in me looking at data. I will tell you that my biggest concern is that the access to care in these medically underserved areas, it still needs physician oversight.
Okay. So since we're talking about rural communities, I want to talk a little bit about proximity of practice. Is there a requirement of proximity of practice to the practice side of the APRN that a physician delegates to?
No, sir.
No. So based on your answer, theoretically, a physician, say in El Paso, can supervise an entire practice of APRNs in Rusk, Texas, which is 760 miles away, right?
Yes.
Okay, and they could do this while never having to physically go to a facility to see any of the patients that are being served. They can do it, the physician only has to check in once with the APRN with their delegated review, and the physician is not required to review care plans or a chart, for example, of the patients that the APRNs are seeing. So you had mentioned that the current framework ensures high quality care for patients and their safety by keeping physicians as the head of the team. I struggle to see how the delegated authority to an unlimited number of APRNs under minimal requirements that we just outlined is quality care and ensuring patient safety.
I agree with you wholeheartedly. And like I said before, we agreed that I would much rather have tighter regulations. But I will tell you, we got blowback by putting too many tight regulations. And what we're trying to do is to maintain a collaboration between a nurse practitioner and a physician. And so I will tell you, if the Senate wants us to have tighter regulation, we can go tighter. My concern is that still having someone with all the expertise that we have, being a physician, that we still need oversight, no matter what that entails and how you decide to legislate that.
So if we get tighter, how do we get access?
If we get tighter, then there might have to be, instead of seeing, like for example, me, I own an infusion clinic, for example. I have a CRNA and a nurse practitioner and a nurse there, but I physically have to meet that patient the first time before we infuse them. I'm also saying that I think that we can do it better collaborating with all of us to make sure that we put patients first. We made it as loose as we can just to have oversight because that was the will of the Texas Nursing Board and the people that were lobbying for that last session.
And TMA's position on that bill, they supported the bill?
Which one? Yes, sir.
SB 406?
Yes, sir.
Okay. So they supported loosening.
Yes, because we came to the table, which I was there, saying that as long as we loosen it, then that way we have more collaboration. I was not trying to make it to where we feel that we should be that loose, but it was all about when we were asked by senators to make sure we collaborated, and that's what we did.
Interesting.
Yes, sir.
I want to go back to to talk a little bit about Senate Bill 406, because you had brought it up, considering the concerns expressed by Texas Medical Association regarding the risk of patient safety, quality care associated with removing those delegatory agreements. Is it the position of the Texas Medical Association that physicians should go back to on-site supervision?
I don't think we need to go back to on-site supervision. I do believe that we need to have physician oversight so we can maintain the patient safety and to maintain lower cost and to maintain decreased delays in care.
So how do you reconcile TMA's conflicting position that more supervision is better for patient safety and outcomes, but be against direct on-site supervision?
I didn't say I'm against it. I don't think you need to have direct physical on-site supervision according to all medical doctors in the way they present medicine, like for a psychiatrist. I don't feel that a psychiatrist needs to be on-site, but I do feel that if I'm a proceduralist, I need to be on-site so I can interact. So what I'm telling you is that it depends on the circumstance, but I definitely want to make sure we can have that conversation.
And I want to focus, primary care is my main focus.
Yes, sir.
Would you agree that APRNs are providing primary care to patients already?
Yes.
Okay. And is it accurate that doctors are not reviewing every single patient file that a delegated APRN sees?
That is 100% accurate.
Okay, so if we're allowing APRNs to practice primary care, which they already do, as you said, without the current delegation requirements, would you agree that we would improve access to primary care in Texas and rural communities?
I would agree that we will improve it, but you still need physician oversight.
This is a really important line of questioning that Senator Blanco is getting into, which is the argument of, well, they're already doing it, so why not let them continue to do it? And it's all about access. And if I were responding to that, I would discuss the fact that it's not just about access. It's about access to quality care. And I would point to the Lancet paper from, I believe, 2019 that showed that more people die worldwide due to poor quality care than die due to no care at all. And it sounds counterintuitive, but what they found is that if you see someone that isn't properly trained, you may get the wrong diagnosis, you may get put on medications that are not correct, that have side effects, and you may delay getting the proper care, and that actually leads to more deaths. So it's not just about access. It's about quality care, people that are properly trained. We know nurse practitioners don't have as extensive an education or training as physicians. We also know from studies, including the Burlington trial, which was one of the first studies on highly qualified advanced practice nurses, showing that even when they worked side by side with physicians, that patients, they got great care, but only as good as physicians up to about 70% of the time. And so we don't really know what care looks like when nurse practitioners are taking care of average patients, undifferentiated conditions, and especially when they are not being supervised. There's just no data on that. And really, by allowing that type of practice, really the legislators are just kind of allowing a big experiment, and the people that are going to be the recipients of that experiment are more likely to be patients in rural areas, patients who are underserved, and I think those patients, just like anyone, deserve access to high quality care.
Okay. In Texas, we believe, from my perspective, in personal responsibility and patient freedom. With that said, do you think patients should be able to choose the type of care that they want and from whom?
I think they already choose the kind of care they want. We do not force, neither nurse practitioner or physician force a patient to go to whatever they want to. That's why we look at adequate networks. We look based on making sure that they have choice to where he or her wants to go get care.
This is another one that I would love to respond to, whether patients should have a choice. Of course they should have a choice, but patients expect there to be a physician overseeing their care. That's what AMA surveys of patients have shown. But by allowing nurse practitioner independent practice, you're actually restricting patients' access to choosing a physician. Of course, someone can hang a shingle, physician or nurse practitioner, but the reality is that more physicians and NPs are employed than own themselves. And so what we see is in independent practice states that many companies, corporations, and even government entities are replacing physicians with non-physician practitioners because they can pay them less, they're less expensive. So by allowing independent practice, I believe you're actually restricting patients' freedom to choose to be able to see a physician. There's still quite a bit more questioning from other legislators, but I think I'm going to leave it there for now, and we'll return next time with the continuation of that questioning and what we can learn from legislators. Thank you so much for listening to this podcast episode. I hope you enjoyed it. If you would like to learn more about this topic, I encourage you to get the book Patients at Risk: The Rise of the Nurse Practitioner and Physician Assisted in Healthcare, and the follow-up book, Imposter Doctors, Patients at Risk. They're both available on Amazon and at barnesandnoble.com. If you're a physician and you'd like to learn more about advocating for our mission, which is ensuring physician-led care for all patients and truth and transparency among healthcare practitioners, then I encourage you to join the group Physicians for Patient Protection. You can learn about how to do that at our website, physiciansforpatientprotection.org. Thanks so much, and I'll see you in the next podcast.